The federal government officially begins discussions on a new health care accord this week. Now, the talks will define the fiscal and social policy relationship between Ottawa and the provinces for years to come. Health Minister Leona Aglukkaq meets her provincial counterparts in Halifax on Friday for their first formal negotiations on how to reform and pay for health care after the current agreement expires in 2014.
Billions of dollars and the quality of hospitals, treatments, and prevention measures are at stake. Critics fear the fiscal squeeze will mean privatization or cuts to health care, and they may plan to take their concerns known from the sidelines. But since the recent round of provincial elections means many of the provincial health ministers are new to their jobs, and since Ottawa has already promised to maintain 6% annual funding increases until 2016, well, the tough decisions are still a long way off.
So what are those tough decisions? Let's ask Matthew Lister. He's the founder and president of Practicalignment Incorporated. That's a health system forecasting firm based in Toronto. Matthew, first and foremost, do Canadians get good value for their healthcare dollars?
That's a great question. I think that when we look at international comparisons, Canadians are, and when I say that, I'm referring to things such as infant mortality and life expectancy. I think that Canadians are getting a fair value, but what we really need to see are the sorts of improvements and commitments that we're seeing in other countries, such as Sweden and other emerging areas like Turkey.
Matthew, do you want to elaborate on that, the kinds of commitments you're talking about?
Yes, Sweden has a national guarantee of care, so this is a federally supported commitment. And what it means is that if a citizen wants to see a family physician, the family physician must see that patient within 3 days. If a specialist is involved, then the patient has to be seen within 10 days. And if at that point the specialist deems that, that there is a medically necessary procedure required, that care, that treatment must be provided within 90 days. So those sorts of commitments with concrete goals are the sorts of things that I think we should see in any further accord.
Is that realistic here in Canada, Matthew?
We've already seen some outcomes like that. Certain rates for breast cancer surgery, for example, are below the targets, and I'm speaking specifically of Ontario's. But in other areas, I think that we could do better. We have invested a tremendous amount of money in information technology and in other services. There are opportunities to consider where that money could be spent and how it could be spent for direct care.
There's always concerns about costs going up, and I'm a big believer that every system needs to be reviewed, and there's always a way of cutting costs at the same time. In Canada, we feel, right or wrongly, that our health care is free. We pay for it, but we don't pay for it directly. So the idea of I can go to the doctor anytime I want, I don't have to write a check or give my visa or bring cash, it's free. Doesn't that mean that more people are actually using the system than maybe they need to? And is there a way to cut back on that?
Well, that's a very good case in point. We do have a sense that it is free, and we forget that every time that we pay our taxes, that in fact there is a significant cost. There are other countries, and people commonly refer to areas like Sweden and the Scandinavian countries as exemplars of outstanding health care. China is often cited as another place where there are assumptions about a socialized form of medicine. In fact, those countries have user fees at the point of admission to a hospital. And in the words of a recent report from the Canadian College of Health Leaders, those user fees very often act as not so much as a deterrent, but a sort of think twice before using the system.
Are they relatively low, but just enough to make you think twice?
They are. Relatively speaking, in China, they're higher, but they are relatively low.
Matthew, is there a need for a second, private tier of healthcare in this country? Because we seem to hang on to this single tier, publicly funded healthcare system. What about a second tier?
It's interesting. An author named David Gratzer a number of years ago in a book called Code Blue made a point that there are in fact several tiers already in existence in Canada's healthcare system. That different people are entitled to either quicker access of services or more comprehensive types of service. But the issue of public-private is really one that I think can be represented and spoken to in different ways. Canada is the only country among the G50 that has a single-payer system. That's very important to keep in mind. We're looking at countries like Singapore, Turkey, Germany, And each of those countries has a private component or a private insurance component. Sweden does as well, Japan, Israel. But within that spectrum of private care, what's often, and there's a reason why the most recent study did deliberately not consider the United States, is because people have a tendency, Canadians have a tendency to look at what's happening in the United States and think that if we were to have an insurance system or a private insurance system like that, then it would have to be like theirs. In fact, there is a very, very broad spectrum of insurance possibilities, and countries like Israel, for example, that have not-for-profit insurance are ones that might be worth considering.
Okay, so what's the likelihood of that being considered and that actually changing? Because we've talked about it a fair amount in the last, say, 3 to 6 months. But is it a real possibility? Are Canadians ever going to see this?
Well, Liz, you made a point earlier about the need to have shall I call it a constant vigilance about the system and ways of improving the system and cutting costs and so on. I think that that sort of mechanism, at least looking at it and studying its feasibility, is something that is necessary in Canada. We should always be looking for ways to improve our health system.
Yeah.
We should be looking for ways to improve every system that we provide. And as long as there are people waiting for care who are not getting the care as quickly as they think they need, there should be ways and there should be organizations or units that specifically are tasked with researching alternatives.
Matthew Lister is the founder and president of Practical Alignment Incorporated. Matthew, thanks so much for joining us today. We really appreciate you enlightening us on our healthcare system.
Thank you, Mark. Thank you, Liz.
Back. We've got new research. It suggests that the kind of, that catty behavior you see the women engaging in on shows like The Bachelor, well, it's actually pretty realistic.
It's my favorite show, by the way. You know what, Liz? Don't expect a similar study that shows men engaging in the same kind of sexual shenanigans. The battle of the sexes, front and center once again, next on Square Off.